Good afternoon, folks. This is Bob Hecker, and today we are going to talk about trauma care. The trauma system in Louisiana was started in 2004 based on a federal mandate that trauma registries had to be created and maintained in all 50 states. This was to ensure that equal care, no matter where you were, was going to be available to any patient that is involved in a traumatic injury. Also, it became a resource for all. The emergency care response systems all have the state names in them. Hence, we have Lern for Louisiana, Louisiana Emergency Response Network, and like Mississippi, MERN, and then of course Texas would be TURN, etc. You get it. We're lucky because there's only one L state in the United States. Other people have to share the M's and the T's and the N's, etc. So, anyhow. Also, what we're going to do is discuss the trauma level center capabilities and how the Louisiana system actually works for us. Okay, so the Lern system for Louisiana, this is their logo and their identifier. They do maintain their own website, and they also are included in most local protocols. St. Tammany Parish Fire District 4 protocol and Region 9 protocol, as well as Region 1 and the rest of the response regions that are tied to the state of Louisiana. There are 9 total subdivisions that have been laid out by the Department of Health and Hospitals and also by the Governor's Office of Homeland Security. All right. So a couple of questions that come up here is, when do I activate Lern? Well, it's a very important question here. First off, you should be putting this phone number in your cell phones, 1-866-320-8293. And your patient has to follow this criteria. First off, an unmanageable airway. We cannot ventilate them. We cannot intubate them. We cannot use our eye gels on the patient. This patient is having major problems with their airway, and we're doing everything that we can to properly ventilate this patient. Also, things such as a tension pneumothorax, if the patient's in traumatic cardiac arrest, quote unquote, a trauma code. A burn patient without a patent airway. Again, burn patients, we need to intubate them because of the swelling of the tissues surrounding their airway. And if we have a burn patient that has greater than 40% burn surface area that we cannot establish an IV on. Again, we are working at the EMR, EMT level, despite the fact we have paramedics on the scene. But this criteria is for everybody so that they understand, when do I have to have a trauma activation? So let's go into a couple of different parts right here. For part 1, we need our life information or the vital sign assessment on our patient. Our Glasgow Coma scale, less than 13, equal to or less than 13. Of course, 15, we would like to have the perfect, where everyone's eyes are open, they're oriented, and they obey all your commands. So take a look at any Glasgow Coma scale chart or trauma score chart, and you are going to see how the point systems work here. Eyes open spontaneously, they get 4. If you ask them a question and they open their eyes, or you shout at them or what have you, then it's a 3. If their eyes open to pain, such as doing a sternal rub or something like that, they get a 2. If they don't open their eyes, they get a 1. On verbal response, are these patients oriented? We're talking person, place, time, event. Are they confused in conversation, but they can't answer your questions? This is somebody that is not oriented to person, place, time, event. They might know who they are, they might know where they're at, but they have no idea what day it is, and they certainly are not aware of any current events around them. They get a 4. For inappropriate responses or words are discernible with these patients, they're awarded a 3. If they have incomprehensible sounds or speech, such as a diabetic with a very low blood sugar, they get a 2. If they're not responding to you all, they get a 1. And then finally, we go look at motor response, motor movement. If you ask them to lift up their right hand, then they get a 6. If they have purposeful movement to painful stimuli, such as if you pinch their hand and they withdraw the hand, well, then that tells us that that has been targeted to that specific region. So they have some cognitive information going on with the brain, so they get a 5. If they withdraw from pain, then you give them a 4. If they exhibit flexion, which is decorticate posturing, you have to remember that decorticate is this way toward the core, and decerebrate is going to be away from the core. And then, of course, no motor response, they get a 1. So when you take a look at minor brain injury, patients got a 15 or higher, we're looking okay. So if they're 13 to 15, that is significant. If it's moderate, they're going to be in the 9 to 12 range. If they're severe, it's going to be between 3 and 8. I hate to say it, but by this score, I can award a rock out in the parking lot a 3, because they're not going to move, they're not going to talk, and they're not going to open their eyes, obviously. That's part 1. Systolic blood pressure. They have a blood pressure less than 90 millimeters. Now, you have to remember the little old lady that's got a normal blood pressure of 80. We will put her in a different category later on in this protocol. So keep that in mind here. And then a respiratory rate of 29 breaths per minute, which require ventilatory support. So we're going to have to use a BVM or something like that. And that also applies if it is less than 20 in an infant under 1 year of age. So we have that criteria to look at as well. So this does address geriatric and pediatric in the protocol. So that's vital sign assessment. Let's go ahead and take a look at injury assessment itself. All penetrating injuries to the head, neck, and torso, the extremities proximal to elbow or knee. So again, if they are shot or stabbed, below the elbow or below the knee, that is really not criteria to put them into the trauma system. However, when in doubt, which would be our last slide, when in doubt, transport to the trauma facility. Chest wall instability or deformities, such as they have a flailed chest or something like that going on here. 2 or more proximal long bone fractures. So even though we were talking about injuries that were proximal to the elbow or the knee, we have to take a look at if they've got 2 broken arms, 2 broken legs, a broken arm, broken leg, etc. Then you were talking about, we've got multi-system fractures right here. We need to take this patient to the trauma center. We also have to look at crushed or degloved, mangled, or pulseless extremity. Amputation proximal to the wrist or ankle. Any pelvic fractures at all. Now, we don't have x-ray machines, but when we were assessing our patient and they went ahead and they winced or they withdrew or they indicated they had pain in the pelvic region, that's going to tell you that something's going on in that region there. So you can bet it's a pelvic fracture, but that has to be confirmed by x-ray, obviously. Open or depressed skull fractures. You can have a skull fracture and not detect it unless an x-ray does it. But if you're doing your assessment as you're supposed to be doing, and your hand all of a sudden comes across a depressed area, as long as you're not Cousin Eddie from the vacation movies with a known plastic plate in his head, I can guarantee you they got a skull fracture. This is definitely criteria that this patient needs to be transported. Any paralysis at all, we have a neurosystem compromise going on here. And any fractures with neuromuscular compromise, such as decreased peripheral pulses or a very prolonged capillary refill, motor or sensory deficit that is distal to those fractures. So these are things that we do have to keep in mind with the mechanism of the injury itself, or the injury assessment period. So just looking at those 8 bullet points: penetrating entry, flailed chest, multiple long bone fractures, amputations that are distal, looking at pelvis instability, skull fractures that are obvious, paralysis, and any pulse motor sensory issues that we have to deal with. Okay, so let's go into the third section here, which is mechanism of injury. We had a discussion about that this morning in a meeting, and this should address that. Falls greater than 20 feet for an adult, that's 1 story, is equal to 10 feet. Or children that are greater, we're looking at greater than 10 feet or 2 to 3 times the height of the child. Even though they seem like they're okay, they definitely have some internal injuries that have to be assessed. So that's why we have to look at these falls. We get guys that slide out of deer stands all the time and end up on the ground. They may end up with a broken leg or something like that. Most hospitals can handle that. You take them to the hospital, they'll go ahead and x-ray it, they'll put them in surgery, they'll set the broken bone. However, there are multiple injuries with somebody like that coming out of a deer stand with a broken joints, broken pelvis, and on, and internal injuries that are not obvious to this patient here. High-risk auto crash here. We're looking at an intrusion including the roof. We're looking at greater than 12 inches toward the occupant, or 18 inches in any other site of the vehicle. So let's say the front end of the bumper were pushed, radiators all the way into the motor. That's greater than 18 inches. And on most cars, they're designed to do that right now, so we have to take that into account. They are going to absorb the energy of that accident. We'll get into kinematics of trauma at a different lecture during PHTLS or ATLS. Let's also go on with ejection, either partial or complete from the automobile. They got ejected out of the vehicle. Or death in the same passenger compartment. Everyone could have been seat belted in, and the guy in the right rear died as a result of his injuries inside the vehicle. We had to extricate him out or whatever. So if there has been death reported inside the same passenger compartment, they should all be treated as a trauma activation right here. Let's look at auto versus pedestrian, such as bicycles or ATVs. If they've been thrown, run over, or if there's been a significant impact of greater than 20 miles an hour. Now you have to remember for pediatrics, usually they get hit and fall down and go under the car. With adults, they get hit, they hit the hood and go up over the car. So that's the up and over right there. And then to answer our question from this morning's discussion, motorcycle crash greater than 20 miles per hour. That is definitely a trauma activation here. Again, internal injuries people don't know about. Adrenaline can mask those injuries. Now, as I was talking about before with the geriatric and the pediatric patients here, we do have special patient consideration here, such as the older adults. Risk of injury and death increases after age 55 years. And we also have to look at hip fractures, such as hip tenderness or a deformity, lateral deviation of the foot, okay, so right lateral shortening. This is excluding isolated hip fractures from the same level falls. So typically the femoral neck is what breaks on a patient, and you're going to find that in the elderly group. That is not the hip itself, but we really can't tell without that x-ray equipment right there. But the lateral rotation usually tells us the hip joint itself is broken, where the medial rotation tends to push us more into the top of the femur broke as opposed to the ball and socket joint itself. Now, also we have to deal with patients that have major joint dislocations, the hip, the knee, the ankle, or the elbow. In that case, we can forget about hip fractures, which was right above. This falls into this next category. Over age 55, we have to take a look at. This is a major problem here because we're going to compromise circulation and also neurological, because you do have nerves that do run through some of these joints, especially the elbow is the most complicated joint in the human body, as opposed to the knee, which is quite easily worked on. Any open fractures, of course, you have exposed the patient, or the patient has exposed themselves to the outside atmosphere and also to the disease process entering into the body. Then finally, we're going to add on here EMS provider judgment. So a patient may have all of this, they may have none of this, but you feel they need to go. And that's a very important part here. We have a lot of power that's been given to us with the EMS provider judgment. Again, we don't want to get in arguments with EMS since we are EMR, EMT responding as first responders, and then EMS arrives to take the patient away. But we still have to look at our scene times. From the time that the injury occurs, the golden hour is what we're talking about for these patients. And lately it's been the platinum 90. But you have to think about the time it gets washed through fire alarm and 911. And when we get to the call, this patient may be already down in that first 10 minutes that the golden hour was looking for us to grab and go. We are not to do any assessment on the scene. We are to get that patient in. We'll do airway, breathing, circulation. That's it. Get them in the ambulance. Everything else is done en route to the hospital. And if you've got a medic that's not capable of doing that, well, then we have to look into retraining of that medic or reassignment or something else. Because this is very much what we do. This is what we've trained to do. Now, you will find this protocol on a website that I do maintain, St. Tammany Parish Fire Training. You can also find it on Lern's website. Just type in Lern, L-E-R-N, on a Google search or Lern Trauma, and this will show up. And this is in all of our protocols. The last update to it was 2016. It did have a couple of revisions prior to that. Again, most of these slides were built off of this specific trauma protocol right here. If you've got no, follow down here. Okay. If you've got yes, it's going to tell you specifically what we're going to do with the patient. And very important there. Okay. So, when in doubt, I want you to transport to a trauma center. These are the trauma centers that are in our area, Region 9. North Oaks Medical Center is a Level 2 trauma center. Lakeview Regional and St. Tammany are both Level 3 trauma centers. And we'll discuss what that means with these trauma centers in just a moment. Okay, finally. All right. Level 1 is capable of providing a comprehensive resource that gives us tertiary care in the trauma system here. They have total care of every aspect of injury from prevention through rehab. Now, Level 1 has 24 hours in-house coverage by general surgeons, prompt availability of care in specialties such as orthopedic surgery, neurosurgery, anesthesiology, emergency medicine, radiology, internal medicine, plastic surgery, you name it, they've got it. One-stop shopping for our patient right here. That's what's very important with the Level 1 trauma centers. The Level 2 trauma, and let's take a look at Level 1. That's going to be Medical Center, Louisiana, New Orleans. That's the Level 1 trauma center. There's another one in Shreveport, but that's a little too far out of our response area that we have to deal with here. Okay, now Level 2 trauma centers right here. What these guys are going to do is they are able to initiate the definitive care for the injured patients here. Again, 24-hour immediate coverage by general surgeons, as well as coverage of specialties of orthopedic surgery, neuro, anesthesiology, emergency medicine, and radiology, and critical care. So, these guys also can provide hemodialysis and microvascular surgery, such as would be needed for handling for amputation care and things like that. They do have a quality comprehensive assessment program. In general, the difference between a Level 1 and a Level 2 facility is the Level 1s are teaching facilities, 24 hours around the clock with everything. Level 2 are also teaching facilities, however, they don't have all the bells and whistles. So North Oaks is the next best thing to slice bread on our side of the lake here. Now, the Level 3 trauma centers here, again, they can provide a prompt assessment, handle resuscitation, surgery, intensive care and stabilization of the injured patients, and emergency operations. So, again, they have transfer agreements to send them to Level 1 or Level 2 facilities. So, St. Tammany is a Level 3 and Lakeview is a Level 3. We'll take your patient, they will stabilize them, and then they will get them to a Level 2 or a Level 1, depending on what Lern has available. So what's nice about Lern is not only will they tell us where to transport the patient to trauma-wise based on the patient's injuries and looking at the area that we're calling from, but they also do maintain a registry where they put physicians in touch with each other immediately so that they can handle the transfer of care from facility to facility. The patient doesn't move until you have an accepting facility. That's what's important here. Okay, now let's talk about level 4 trauma centers again. This is an emergency room physician that is ATLS certified, Advanced Trauma Life Support. The equivalent to that for paramedics and basics would be Pre-Hospital Trauma Life Support, or PHTLS. Again, they will handle a more thorough assessment and they will get that patient to a trauma center ASAP. Again, they're going to intubate the patient, they're going to hang blood, etc. Okay. Then finally, we've got our level 5 systems right here. We have to deal with the dock-in-the-box situations right here. So this is where the patient is going to be assessed. Again, they can hang blood on the patient, and they have to immediately get them out, usually by life flight or something like that. All right, to finish up, guys, if you go ahead to stpft.com, we've got information for you on the front page. Just take a look here at the trauma protocol, and that will give you plenty more information. So without further ado, if you don't have any further questions, or you can email me, rhecker@stpft.com or robert_hecker@stft13.org, and I'll be happy to point you to further resources. Have a great day.